Dr. Bauer, please start.
Dr. Bauer,
Yes, sir.
we are live. Kindly start the program.
Okay, sir. Good evening, respected President Amasi, Varghese sir, Secretary Dr. Deborshi Sharma, and team of Amasi. Today's speaker Dr. H. Ramesh sir, moderator Dr. Senthil Nathan sir, Dr. Malitha from Sri Lanka, and Dr. Roshan Sethi sir, our founder president, Palani Velu sir, and all the delegates who joined this online program from the India as well as from outside India. I welcome all of you for joining this program regularly, because this program is brainchild of our President Varghese sir, and day by day the delegates are joining more and more, so that shows the popularity of this program. So today's CME is the second online CME of the North Zone chapter of Amasi, and in this I welcome all of you, and now I invite our President Dr. C.J. Varghese sir for brief introduction of about this program and today's CME. So now over to C.J. Varghese sir.
Greetings from Amasi, Association of Minimal Access Surgeons of India. Once again, we are back with the Amasi online CME program, done every first Thursday of the month at 8 p.m. I welcome all the delegates to this program. It's conducted by the zones of the Amasi in rotation, and today it will be by the North Zone, and it will be coordinated by the President of the Zone, Dr. Banwarlal Yadav. And today's topic, you very well know that it's on chronic pancreatitis, and Dr. H. Ramesh, an authority on pancreas, is a speaker. I was fortunate to work under Dr. H. Ramesh for 8 years and get trained in GA and laparoscopic surgery. Dr. H. Ramesh has contributed immensely for the introduction and development of GA and laparoscopic surgery in Kerala. Having observed the Teachers' Day a couple of days back, it is an honor to have an eminent surgeon like Dr. H. Ramesh, who has trained many GA and laparoscopic surgeons all over the country for today's program. Today's CME program is done in association with SLAMAS, that is Sri Lankan Association for Minimal Access and Digital Surgeons, under the leadership of Dr. Bhavanda Gaumage, the president of the association. Also happy that to have another expert GA surgeon, Dr. Punither, as the moderator. And Dr. Punither was a long time in Kerala, was the head of the Department of GA Surgery at Amarda, now moved to Amarda Hospital in Faridabad. I welcome Dr. Punither. And we also have another GA surgeon from Sri Lanka, Dr. Malit Nandasena, and our own executive committee member, Dr. P. Sendilnathan, will be joining shortly as the moderators. We are grateful to Merrill Endosurgery for supporting this online CME program. The Amasi also has another online education program happening on every third Thursday between 3 p.m. and 6 p.m. It is a live surgery demonstration by experts in the field. The details of this particular program and all other academic programs will be detailed by our Secretary, Dr. Deborshi Sharma, later. I request you all to be a part of the Amasi and part of the academic programs of the Amasi. Thank you very much. Over to Dr. Banwa.
Thank you, sir, for the brief discussion about today's program. Now I request our secretary, Dr. Deboshi Sharma, for today's quiz program, first quiz program. So now over to Deboshi sir.
Devashi, you are muted.
Sir, unmute please.
Yeah. Thank you, Bhavar. Thank you for the honor to be here among all of you today. My duty is to announce the quiz as well as announce the last quiz winners. The last quiz, which was during the liver resection program in the last year, it was won by two residents, GI surgery residents both. The first one was Dr. Yugal Limbu. He's an MCH resident, third year resident from Kathmandu Medical College and Teaching Hospital, Sinamangal, Kathmandu, Nepal. Do you have Dr. Yugal Limbu here?
Yes, sir.
Dr. Yugal, you are winner of the first quiz of the last month. We are proud that you are among us today. And the second was won by Jigar Jariwala. He is again a MCH surgical gastroenterology resident, final year from Amrita, Kochi. Dr. Jigar, are you here? Yeah, both of us.
Yes, sir.
Both of you, we welcome you. Would you like to say a few words, Dr. Jigar and Dr. Yogal? Dr. Yogal first.
Yes, sir. Thank you very much, sir, for this opportunity. I think this online series have further enabled us to have international relation with the other faculty members of other countries as well. And it is really a good learning experience. Thank you, sir.
Dr. Yogal, we will be there for the skill course in Kathmandu in the last week of September. We hope to see you there, and we hope to see you during Amasicon also in November in Raipur. Yogal, as I said, is a third-year resident in Kathmandu Medical Teaching Hospital in Nepal. And Jigar, would you like to say a few words? Jigar Jariwala is again a third-year resident in Amrita, Kochi.
Thank you, sir, for this wonderful opportunity. This is a great initiative by Amasi. I urge all my colleagues and co-PGs to regularly see this online program. It will really help in their future endeavors.
You are eligible for a certificate from MSc as well as a cash prize. But I hope you have to be members of MSc. I hope you already are. If not, try to become a MSc member through our website. Moving on to the quiz question for today. As the topic is on pancreas, both the quizzes, as you can guess, will be on pancreas. And if you can show me the slide, the first is what is the earliest and most severely affected malabsorption in chronic pancreatitis? It is A, B, C, D. You have to answer that within the next 5 minutes, and the fastest finger is going to get the prize. You can answer it as A, B, C, D, whatever it is you think. What is the most severely affected malabsorption in chronic pancreatitis? We try to make the questions so that the MS PG students also can participate in it. But every time we are seeing that it is the MCS resident. So I request all the MS students, whoever is seeing that, to try to win the prize, which will be announced in the next meeting. So this will be visible for the next 2 minutes, and you can answer this within the next 5 minutes. Thank you. Thank you. Over to Bhavar. Bhavar, you can continue with your program. I'll come back with the next quiz after the end of the lecture, before the discussion starts.
Thank you, Devarshi sir. Now I introduce our today's program's moderator, the two well-known moderator, and I thought there is no need for the introduce the moderator like Dr. P. Senthil Nathan, who is director of JAM Hospital and who is well-known gastroenterologist and has a special interest in hepatopancreatobiliary surgery, and sir is always in wherever there is even AMASI activity, ASI activity, even any other activity related to GI surgery. And other moderator is Puneet Dhar sir, who is head of surgical gastroenterology from Amrita Hospital, Faridabad. So both moderators are well known, and there is no need for the more introduction. And third moderator from the Sri Lanka, who is Dr. Malit Nanda Sena, who is consultant surgeon and senior lecturer in Colombo South Teaching Hospital, Sri Lanka, who is faculty in medical science, University of Jayawardhanepura, Sri Lanka. And Dr. Malik Nanda Sena has passed his MBBS in 2009 and completed his post-graduation and MRCS, FRCS up to in 2016, and then joined the university as a faculty. And he has also a special interest in the hepatopancreatobiliary surgery. Now I request Dr. Puneet Dhar, sir, to introduce our today's speaker, Dr. S. Ramesh, sir. So now over to Puneet Dhar, sir. Sir, please.
Thank you. I don't think it's normally it's a trite thing to say that you don't need to introduce the speaker who's so well known. But in Ramesh's case and chronic pancreatitis, I don't think it's an understatement. And I think everybody in India at least identifies, and many abroad also. He's done so much work on chronic pancreatitis. It's almost been like a life mission for him, even though he is one of the brightest surgeons in the country that I've met, intelligence-wise, but also very skilled and a very good teacher. I love to see his passion when he's with the students. So I'm so excited that MRC has brought out this session directly to connect with them. And there's no better person than Ramesh to set the ball rolling. Thank you.
Thank you, sir. Now I request Dr. S. Ramesh, sir, for the presentation. Sir, please.
Good evening, ladies and gentlemen. I must thank MRC in general, my old friend and colleague, Dr. C.J. Varghese in particular, Puneet, Sendil, Dr. Malik Nandasena from Sri Lanka, and the office bearers of the MRC for inviting me to participate in this program. I began by being a founder treasurer of the MRC, but somewhere along the line, I think I dropped being a member. So I don't know, if my membership is still active. And the second thing that I wanted to say as a disclaimer is that I explained to Dr. Varghese that the majority of patients with chronic pancreatitis are still treated by non-laparoscopic techniques or open surgical techniques. And would it be out of place in an MRC forum? But apparently the message is that you have to be minimally invasive, whether you make a big incision or not. And on that note, let me try and summarize some of our current understanding in the area of chronic pancreatitis, and certainly look critically as to how many of these procedures can be done laparoscopically. It's important to start at the outset by saying that a very close liaison between the physician, the surgeon, the endocrinologist, the endoscopist, if you like, if there is a special breed of MIS surgeon in the unit, and then a nutritionist is critical to achieving good outcomes in chronic pancreatitis. And too often the compartmentalization of healthcare has ensured that this is a very distant dream at this time. Otherwise, you will have disasters like these. I'm going to just discuss 4 aspects, some definitions and some home truths. And I want to start by defining chronic pancreatitis, that there is an irreversibility of these changes in the parenchyma and the ductal elements of the pancreas. And it largely falls in 4 categories: chronic calcifying pancreatitis, autoimmune pancreatitis, group pancreatitis, and obstructive pancreatitis. And the reason I said obstructive pancreatitis last is because this is a special entity where there are no calculi, no fibrosis, no functional deficiency, and it's all because of some single obstruction, in this case a pseudocyst producing upstream dilatation, where drainage of this pseudocyst will actually be curative. And this is probably the one reversible entity of chronic pancreatitis, and this is something we must be aware, because we mustn't squander the opportunity for reversal of the disease. The disease presents anywhere from being asymptomatic, mild or severe abdominal pain, functional deficiencies and complications, and with pathomorphologically calculi, gland enlargement or atrophy, abscesses, inflammations, and ductal strictures and disruptions, and of course, involvement of adjacent organs like the duodenum, the bile duct, the pancreatic duct itself, and the portal system. If you have any patient with chronic pancreatitis, one asks ourselves three critical questions. Is there pain? Are there complications? And what is the functional status of the pancreas? And accordingly, about 21 years ago, I proposed this grading system where I divided those patients into those with no pain, that is A, those who had pain but no complications, that is B, and those with complications, C, and subdivided each of these into 0, 1, 2, or 3, depending on whether there was diabetes or steatorrhea. 1 if it's diabetes only, 2 if it's steatorrhea only, and 3 if it's both diabetes and steatorrhea. Thereby, if you had a patient who had A0, it was easy to understand in the common lingo that we were dealing with a patient who had no pain whatsoever and who had no functional deficiency, at least overt functional deficiency, that is. On the other hand, if you had C3, you realize that the patient had both diabetes and steatorrhea and then had complications. Now you can then ask what complication it was. If you add a thorough imaging of the pancreas and the peripancreatic area to this classification, you have pretty much the entire problem understood and distilled for you to commence management. The two commonest causes of chronic pancreatitis being alcohol abuse and idiopathic, which is also referred to in some areas as tropical. And I recommend that we approach the condition with a holistic approach, which certainly includes social rehabilitation, including de-addiction from substance abuse and dependence. And many patients have economic, deprivation, and they have lost their livelihoods. Many of them need to be rehabilitated into useful jobs, which produces income. They also have to be, the nutrition has to be taken care because pancreatic enzyme replacement allows fat-soluble vitamin and vitamin D to be used in the body. The diabetes mellitus is a type 3C diabetes, which is type 2, similar to type 1, but there is not complete loss of beta cell function like type 1. While the patients are insulin dependent, a substantial number of them are able to be managed even on metformin alone. And there is also a problem with the alpha cells, because of which there is an impediment to glucagon production. And therefore, there's more hypoglycemia, but less diabetic ketoacidosis. If you do this holistic approach, and in addition, you do procedures or treatments to relieve pain and to treat complications, you have it pretty much in the bag. What if the patient has no symptoms? The patient could have no diabetes or steatorrhea, diabetes alone, steatorrhea alone, or diabetes and steatorrhea. If it's A0, I think everyone would agree that you should only follow up, except if there was a specific finding such as an abdominal mass in the pancreas, which suggested there was a neoplasm, which can sometimes be asymptomatic, and then it would need appropriate management. Medical management of type 3C diabetes is the appropriate treatment for A1, pancreatic enzyme replacement for A2, and medical therapy in the form of both diabetes and steatorrhea treatment for type 3. It is generally agreed that neither endotherapy nor surgery should be exhibited to these patients because there is no indication for the same. The 4 groups of treatment options that we have, medical, endoscopic, 3 groups of treatment options, the medical, endoscopic, and surgical. I wish to emphasize that pancreatic enzymes really do not relieve pain. Even the protease-rich pancreatic enzymes do not relieve pain. Antioxidants, the jury is still out because the results are mixed. Pramod Garg's randomized trial showed benefit, provided a high methionine is included, whereas the Anticipate study from Manchester did not. And Manchester was actually the real temple of antioxidant use with the Joan Braganza table. And it's surprising when they have negative results, it must be taken seriously. Endoscopic treatments are generally confined to those patients who have proximal strictures. When I say proximal strictures, strictures close to the ampulla, those with dilated ducts, of course, no mass, who have ductal disruptions, they are eminently suited to stenting, and biliary obstruction, where it may often have only a temporizing effect. If you consider surgical treatments, they come in 5 groups: drainage procedures, resection procedures, hybrid procedures, nerve interruption procedures, and islet cell transplantation. And I'll touch on them briefly. It's also good when you are looking at the morphology of the pancreas to look at whether you're dealing with large duct disease, where the duct diameter is 5 millimeters or more, small duct disease if the diameter is 4 millimeters or less, and if there are mass lesions. And while endoscopy can and certainly will work in many patients with dilated ducts, they do not work in the other 2, where surgery is the option. My second task is to address or summarize the surgical approach to this condition. The big 4 operations for chronic pancreatitis range from the Partington-Rochelle modification of the Puster-Gillespie procedure, which simply meant a lateral ductotomy from head to tail and an onlay anastomosis to a Roux-en-Y loop of jejunum. This did not succeed because the head remained an area of difficulty and was inadequately drained. The other extreme was to do a Whipple resection, and this was the North American solution to chronic pancreatitis. Take the head out because the head was considered the pacemaker. That did work in terms of pain relief, but there was so much pancreatic dysfunction because of pancreatocybal asynchrony as well as loss of the duodenum. And therefore, hybrid procedures were introduced. The Bega procedure in the 1970s from Ulm in Germany, in northwestern Europe, where a subtotal resection of the head was carried out. The pancreatic body and tail was not filleted out, and both of these were anastomosed to jejunum. And after, of course, transection of the neck. Whereas in the Fry procedure, there was no transection of the neck. The lateral drainage, along with the head coring of the head, was carried out. An ideal procedure, to my mind, should deal with the entire gland, because this is a progressive disease. And if you just deal with the tail because there is a tail problem, it could be a head problem in a few years. And so it's better to have an operation which will fix the entire gland. It should preserve pancreatic parenchyma, because if you remove the pancreatic parenchyma, and you can relieve pain, but the functional results are so disastrous, and that can impact the quality of life. It must, of course, be safe with practically zero mortality and accepted morbidity, durable in the long term, and should be able to deal with complications should they be present. And so our choice has been to use the Fry procedure from right up beyond 1994, and we haven't changed except briefly to do the Bega procedure, and I shall explain that in a few minutes. So the experience that we have gained between 1987 and 2021 largely rested on our experience with the Fry procedure, where only a small rind of pancreatic tissue was allowed to remain to protect the duodenum, the portal vein, the superior mesenteric vein, and the inferior and the superior portions of the duodenum, and posteriorly it practically reached the posterior capsule. As in contrast with children, where often the head is so small that a lateral pancreatogegnostomy tantamounts to being a Fry procedure, this patient, of course, had a very distant pseudocyst to which the end of the loop was anastomosed, and the side of the loop was anastomosed to the side of the pancreatic duct. We must study the pancreatic gland and duct morphology carefully, because if you have a patient who has a stricture in the body-tail junction, and if your stent only reached up to the body, you cannot have pain relief. And only when you laid open the dilated duct beyond, there was pain relief. If you had cysts in the tail, there's no use talking about the pancreatic head being the pacemaker. one had to address this specifically and drain the cyst in continuity with the main pancreatic duct. Occasionally, you can have real difficult situations where the cyst actually lies posterior to the pancreatic duct and straddling this origin of the superior mesenteric artery. And in case that situation, you have to gingerly make up an opening in the posterior wall of the pancreatic duct and mature a communication between the two to achieve good results. Our own preference is to do this head coring in a very meticulous, in a very precise way, without taking a large scoop in one go, but to only take small bits at a time, which allows you to have hemostasis, to see what you're doing, and also to open up side branches as and when they appear, remove calculi. This is a fresh areca nut, which many of you may not have seen. It's really very succulent and easy to cut when it's fresh. So you can take sequential cores in each place. Each time you have to pause and look for side branches, as I will show you in a genuine video. And I'm just going to show you part of a video of so with the hand behind the duodenum to control the bleeding if present, to also guide the extent of the head coring, you can use electrocautery. We haven't found harmonic to be particularly efficient in this regard to do the coring. And as you core, one will encounter ductal moieties where strictures have prevented the stones from draining. And each of these ducts can be laid open. And so you have a spidery head consisting in the most part of the capsule, but also a kind of spidery back end of the pancreatic duct. And you can see the stones being removed here. So at the top, you saw a glimpse of the main pancreatic duct, and you saw the deep head coring. Bipolar electrocautery of 4-proline is used to achieve hemostasis. Attention is being given to the other inferior border of the pancreas. Please notice the superior mesenteric vein here. And you can see that a new ductal moiety is also opened up, something that would not be seen otherwise. Bipolar is eminently sufficient for small bleeders like this. Larger ones, of course, we would suture ligate, and calculi can be removed. It would be quite appropriate to do intraoperative X-rays with a low kilowatt exposure so that you can see all the calculi and correlate it with the preoperative scans. And at the end of this procedure, there would be very little pancreatic parenchyma left at the back and on the sides. And you can see that the hemostasis is rather thorough prior to anastomosis. So our own departmental 10 commandments would to be ensure a very good mobilization. This is not enough. The entire mesocolon has to go down. The superior mesenteric vein has to be seen. The gastrocolic trunk is divided. The upper and lower borders are mobilized so that the pancreas actually is released from the electroperitoneum, and it enables further, clear identification of the football pitch that you have to work within. Otherwise, we tend to tread, especially in laparoscopic surgery, to areas beyond the pancreas. And the gastroepiploic vessels are also ligated. Eventually, the gastroduodenal is ligated in continuity. And then if you get the duct in the body, that's fine. Otherwise, you can core the head and discover the duct. 2-layer anastomosis is what we would prefer. And in patients who have an inflamed pancreas or patients who have hyperproteinemia or nutritional compromise, we would add a feeding jejunostomy. The long-term results of our patients, which were published in 2012, showed a 5-year pain relief number of 93%, which was quite gratifying. And this was true even when the ducts were narrow, as we could see a 3 millimeter duct, which could be anastomosed. And this was published exactly 20 years ago in the International Journal of Hepatopancreatability Surgery. These two hubs of the hypodermic needle have been placed in 2 ductal disruptions, which had resulted in pancreatic pseudocysts and pancreatic pleural effusions. And it just shows you how narrow the duct is. And the pain relief was 94% at the intermediate term. Now, these patients have been followed up for a long time, and they continue to remain well, and those data is being published shortly. In any case, we have to count our chickens carefully, outcomes objectively and carefully. We have to have functional pain scores, endocrine assessment, exocrine assessment, and last but by no means least, the quality of life assessments. And we prefer the EORT, CQL, Q30. There is a PAN 28 module which is available, which can be added to that, which is specific to chronic pancreatitis, and that is our preferred modality for assessment of the objective assessment of the quality of life after surgery and before surgery. What about the timing of surgery itself? Do we let patients earn their surgery, or do we do them early? I do know that the ESCAPE randomized trial suggested that overall the outcomes may be better if you intervene early. There is also some data suggesting that the earlier you intervene, the more functionally viable the pancreas will remain. But I tend to look at the other side of it, that if pain has occurred and pain is debilitating or disabling, it does not serve any real purpose to let the patient go on for years and years with pain, diabetes, and functional deficiency, and go into this vicious cycle of drug dependence or alcoholism. And perhaps one considers that many of our patients committed suicides. Many of them had systemic complications of diabetes. If you have a patient who's clearly symptomatic and whose symptoms are interfering with or her lifestyle, it may be worthwhile offering the intervention substantially earlier rather than waiting and waiting. This is exactly why we mustn't do a total we mustn't have a patient who requires a total pancreatectomy, because it has been shown in Mr. Russell's group that if you waited until patients were basket cases and their nerves and neurons were completely maximally stimulated and neuroplastic, then they would continue to have pain even if you took away their pancreas. So you don't want that to happen. You want to intervene before that. The other critical thing is that many people expect that patients must be free of all these substance abuses before they are operated. That's not fair, because as long as pain continues, patients cannot be rehabilitated. So these must go side by side. Patients must be counseled, and they must have the willingness to enroll in a systematic program. They must have some intervention which relieves pain, and then, of course, the therapy must continue. The biggest concern in chronic pancreatitis is that the 4 major pillars of outcomes in chronic pancreatitis, mortality, morbidity, pain relief, and quality of life, are all interlinked, and pain being, of course, a dominant feature. Now I come to a very interesting and a very exciting area in treatment of chronic pancreatitis. I believe that chronic pancreatitis surgery is tailor-made for minimally invasive surgery, because we don't need a specimen extraction incision, which, for example, if when one performs a laparoscopic low anterior resection, it having done a very outstanding mobilization and stapled anastomosis, low rectal anastomosis, then we have to perhaps to really place an incision to remove the specimen, and so it's true for a donor nephrectomy. However, here we don't need such an incision, and therefore it should be tailor-made for MIS. But there are issues. The first is the lateral pancreatogenostomy, which is eminently doable technically laparoscopically, has rather become a thing of the past. Because if you looked at the curves from the year 2000 or 1990s, you find that there has been a steady increase in Frey procedures. Initially, it was all LPJs in the papers published. Then the Bega procedure took over in the late 1990s and in the 2000s. And then the Bega procedure slowly subsided when people realized that transection of the neck is not the easiest task. And now the Frey procedure is way ahead of the others. I can safely say in India that this is the go-to operation for painful chronic pancreatitis. The second is that because it's a progressive disease, you need to look at long-term follow-up, and counting your chickens before they are hatched can be a bad plan. So we need long-term follow-up, and our long-term follow-up even in 2012 was 112 months median. And that's the sort of follow-up you require to say that these patients are doing well. So it's not the early results that are going to govern long-term outcomes. So although it is always attractive to have early outcomes as well. The other concern is that our own data showed that during 3 time periods, up to 1997, up to 2004 and beyond, we became more radical because patients came back with recurrent symptoms and signs which merited re-intervention. And we began to realize that re-intervention is a surrogate marker of lack of the adequacy of the first procedure. So from just removing a triangular wedge of head, which is what Charlie Fry described, we began to clear the duct up to the papilla, clear the sentinel stone, and also clear the inferior part of the main pancreatic duct below the MPD into the Ansonet process. And in the last phase, we also began to match the intraoperative findings with the preoperative scans and also do a Fry procedure in every case. It's only the magnitude of the Fry that will be different, the amount of grams of pancreatic tissue that will be different, removed, that will be different, but it will be done in all cases. And with that, we had, of course, 96 interventions in 60 patients, which is 8.4%. We discovered that in Group A, 30% of patients required re-interventions, which came to 10% in the second group. And in the third group, it is 2.5%. And most of the problems were due to head issues, strictures, stones in the head, biliary obstructions, inflammatory head mass, pseudocysts in the head. And just reflects that where the earlier Fry failed was in providing enough solutions in the head. And many of these patients underwent endoscopy or surgical procedures, including re-head coring and Whipple resections, biliary drainage procedures. So it appears, therefore, that the more thorough the Fry, the better. And also the first operation may be the best, because our earliest publication in 1992 suggested that a re-operation for chronic pancreatitis can be one cause of death. That can be hazardous for the patient. So if you put all these things and say that the first chance is the best, although in a patient with severe inflammation, you may have to limit the procedure and come back again and also do a thorough procedure, then you understand that perhaps the Fry procedure is the best. And while there have been ample publications, mostly from our country, of laparoscopic pure store in chronic pancreatitis, the numbers from many of these units who are very, very busy units with large volumes is still surprisingly low, or not surprisingly low. Amit Javed's 41 cases from Delhi stands out here. Whereas the Fry procedure group is substantially smaller. And it's obviously that the technical issues with the adequate Fry have been a big problem. One of the papers was published in BJS Open by Senthil's group from Coimbatore and Chennai. Hridaya Nag from JP Pant, in these 33 cases, he did have Fry procedures, which he actually tried to case match with the laparoscopic and open group. And he was able to show that the results were kind of similar. The 3 comparative studies, better outcomes with the laparoscopic, Fry procedure rather than the laparoscopic pancreatic, which was not a big deal. This was the paper of Hridaya Nag, where he used a matched format for age and the type of surgical procedure, which showed comparable outcomes. And Senthil's data was interesting because it showed that he did perform 15 Fry procedures, but some of them had to be converted, either because duct was not identified, because there was bleeding, or because there was doubt of cancer. So he preferred to do a modified Fry procedure. Japanese surgeons also favor that if you take out the gland only up to the main pancreatic duct, but not beyond, then you have achieved a modified Fry. And while it's quite all right to say that the early results are comparable, considering that this is a progressive disease, I would much rather vote for a more thorough drainage right up to the common bile duct, as is seen in this diagram. So I'm going to show you a video kindly provided to me by Kalerasan from JIPMA, and this is the in a way a resurrection of the beggar procedure. It's very difficult to do a good fry procedure laparoscopically or by robotic surgery because you can't get at the back end. And this is what you miss. If you can't have a hand at the back to guide your extent, right now the entire head is in your hand. The pancreas has been virtually riddled with the ductotomies, and the entire calculus and stricturus area has been laid open, and there is practically nothing left. And that allows you a good outcome. But you can do a beggar procedure, transect the neck, that provided the inflammation is less. And I'll show you an example of where it can be difficult. If you retract the pancreatic head over to the left extracorporeally, you can then proceed to mobilize the pancreatic head. And in many of these patients with mild to moderate inflammation, and you can see there's actually some edema in this case, you can discover a plane between the pancreatic capsule and the pancreatic parenchyma. And the eminently facile monopolar forceps of the robot allows you to do this in a rather hemostatic way. You can ligate only those blood vessels which are coming into the pancreas. You can use ICG to know exactly where your bile duct is, and that is using the Firefly. You can quickly toggle to and back, and therefore make it a very fruitful procedure. And once you have mobilized the head of the bile duct, you can again repeat your ICG and notice that you have got more and more bile duct exposed. You haven't opened the bile duct yet. And you can see the blood vessels coming into the pancreas. These are beyond the bile duct and they can be ligated eminently. So when you complete the procedure superiorly, you find that the bile duct is pretty much exposed but not traumatized. And then you enter the main pancreatic duct in a second, and then you can remove a stone, sentinel stone. You please notice that you're very close to the duodenum, and then the same operation has to be carried out on the inferior extent using again ICG, and the specimen is removed. Once the specimen is removed, you will notice that you have a short stump of the pancreatic duct, which is just away from the bile duct. If you hit the ICG button, then you get you know exactly how close you are to the bile duct. Eminently doable operation, provided the inflammation is less, and in that you can actually have as near total excision of the head and a good clearance of the head, as you can see in this picture. But this cannot be done if you have a wall of inflammation around the pancreas. Ladies and gentlemen, traditionally, chronic pancreatitis is a disease of inflammation, which means the peripancreatic tissues are completely covered by a wall of inflammation, as opposed to, say, malignancy, where the perioperative planes are beautifully inviting. In this situation, creating the tunnel over the superior mesenteric vein and under the neck of the pancreas can be very hazardous, even to the experienced. And since we need a lateral drainage anywhere, the video that I showed you before, the surgeon did do a lateral drainage as well. So that was a kind of a halfway house between the beggar and the fry. So we do need a lateral drainage because 40% of our patients have body and tail disease, and that has been published. So we may still not be able to do a beggar procedure in a case like this easily and safely, and we still have to resort only to the fry procedure. And when you do that, the limitations of the laparoscopy show up. I want to end with a little tidbit of desert. This is a very interesting CT scan and contrast enhanced CT scan showing an extremely atrophic gland due to chronic pancreatitis and calculi. But please notice the area of enhancement within the atrophic gland and the atrophic duct, and that's a dead, as a giveaway as far as cancer is concerned. And this patient actually had histologically proven cancer and underwent a Whipple resection. And last but not the least, what do you do when you have recurrent pain after surgery? First of all, you need a checklist like this. You have to look for peptic ulcer, gallstones, other diseases which may be the cause. Sometimes patients with substance dependence have a highly hypersensitive response to pain, and they just refuse to stop having pain. And you may have to, they may have to undergo an extensive rehabilitatory process. Patients with hyperparathyroidism may continue to have symptoms. If there is a complication that has happened after the surgery, it happens generally because you haven't tackled the pancreatic gland and the duct adequately enough. You can have biliary obstruction, you can have a new inflammatory head mass, you can have portal vein obstruction, and you can even have a pseudocyst, as we showed in our own data. Then, of course, you have to address each of those. The other question you have to ask ourselves is whether we are dealing with a possible cancer. An EUS FNA ad nauseum is worthwhile. Using a ROSE or a rapid on-site examination will permit several passes, up to 12 passes, to see that you get tissue and you are able to rule out cancer. Having done that, now you have recurrent pain. Do re-examine the morphology of the gland and the duct. Too often, my surgical colleagues, my medical colleagues try to write these cases off as basket cases. But if you spend time, energy, and imaging, you can always find a solution to the problem, of course, with the rare exceptions. Also try to find out where the residual calculi are and deal with them either by endotherapy. I may mention here that if you do an adequate fry and if you have residual disease in the head, endotherapy works tremendously well. And when you cannulate the ampulla, and if your drug, the contrast injection actually enters the jejunal loop, it's a surefire success. So on that note, having re-emphasized the importance of coordinated and multidisciplinary approach to this disease, I thank you for your attention, and Amasi once again for the opportunity.
Thanks so much. Thanks so much, Ramesh.
Sir, thank you, sir. Sir, first I invite Deborshi sir for the quiz. Then we will start discussing. Deborshi sir.
Should we open the chat box so that people can put questions there? The chat box is sort of disabled.
So as Deborshi is getting ready with his quiz, can I start a few questions, sir? Ramesh sir, good evening.
Good evening.
Roshan sir, can you start the quiz, sir? I will share the screen.
I can do that. Okay. Could you put on the slide, please? Yeah, so the next question is, what is the most commonly used tumor marker for pancreatic adenocarcinoma? A is CA19-9, B is mutations of KRAS, C is AFP and HCG, and D is CA125. So fastest finger first will get the prize. So you have to mention A, B, or C, or D, whichever is your choice. Thank you. We can go on for the discussion.
Sir, I'll start the ball rolling. As usual, a very excellent talk, a very nice, lucid overview of chronic pancreatitis from you, a world authority in this specialty. We all continue to learn from you even now, so that we can refine our technique, not only technique, the workup as well as the results. So my question, couple of questions. One is, you are an advocate of doing an extended fries or doing it a maximum, so that you said even sometimes you'll be leaving only the posterior pancreatic capsule if in case that there need be. So my question is, the extent of pancreatic resection or pancreatic denudement, will it cause exocrine or endocrine insufficiency in the long run? Because patient usually ask, will this particular surgery will cause either an exocrine endocrine insufficiency, especially diabetes? So what is your take on what needs to be informed to the patients?
So first of all, about 55% of our patients have either diabetes or abnormal glucose tolerance. 45 patients are not diabetic at the time of their presentation to the hospital. Now, the question that is asked is, will a more radical or extended fry mean more pancreatic functional loss? At least our data so far, and it means at least 10-year follow-up, does not seem to be the case. As long as the duodenum is preserved, it appears that patients have very similar functional results. And so I would be happy to tell my patients that you are not going to get diabetic because of the operation. You could get diabetic just as it is, because Kerala, Tamil Nadu, Gujarat, most parts of India, and India itself is the diabetic capital of the world. And I will point to any number of patients who are not having chronic pancreatitis who have diabetes. So this operation is not designed to prevent you from having diabetes, but 16% of our patients over 10 years later had actually amelioration of diabetes, or they went off off drugs. So there is a small fraction which improves, but that's not the reason the operation is done. The operation is done for pain relief and for relief of complications. So diabetes may happen. Diabetes may happen in 6 months' time or 6 years' time or never at all. And it is not usually due to the drug, but it's usually due to the fact that your pancreas is a diseased one.
And the second question is, I wanted to ask is, you said 40% of the disease will be restricted to the head. In our situations, what we commonly see, 40% will extend to the body and tail, but we see more body and tail disease also. To the extent I don't have the data, but our experience has shown that we have got a reasonably good stone load, even body and tail. So lateral drainage definitely is required, sir. But have you had experience of doing a body coring or tail coring or a tail pancreatectomy?
Tail coring, very much, yes. We have 11 patients who have had tail coring. The point is, whenever there is an inflammatory mass, the inflammatory mass can happen anywhere in the pancreas. In the head, it can become a very complex mass, but in the body and tail, it's a much more dependable mass, an easier mass to deal with. But again, the virtue of mobilization of the superior and inferior borders of the pancreas allows me to sort of decide where my roadmap is, where I need to work within. So especially when I do a body coring or a tail coring, if I have this well-mobilized pancreas, it can be done eminently, even by MIS, it's not a problem. But if you are going to do it without that upper and lower border, it's merging with the retroperitoneum. There is some inflammation which has made everything a little bit of a fibrotic environment. Then that's definitely the starting point for some intraoperative disturbances and potential catastrophe. So I think it's a very relevant point. We actually looked at our data and said what percentage of patients have body and tail disease. When I say tail disease, small stones we did not consider as tail disease. Substantial stone load and strictures, both of them. And that was 40% was the figure. I quite agree that as you see more and more patients in different environments, you are likely to get different figures. But if we put all our data together, we probably will reach a figure which will be more representative. It may be 50%, it may be 60%, but that again, in our country, it underlines the lack of multi-center joint approach to understand the disease completely, which I think we should definitely, maybe MRC could be the ones to initiate it. The physicians haven't been able to bring it together. Maybe the surgeons can do a better job.
Thank you, sir. Thank you for reply. I think any other questions we'll encourage.
We haven't opened up the chat box at all. I think it's still disabled. Ramesh, while they open that up, since it's an MRC sort of meeting, would you like to highlight which are the ones cases you would not like done by the minimally invasive techniques? For instance, small duct disease, that kind of stuff.
So I think Senthil's paper set it out very well. Senthil is a exceptionally good laparoscopic surgeon, and he did not lack for obviously technical skills. What was the problem was that you couldn't find the duct in some cases. You had a mass lesion where you were suspected cancer. That was another reason. And what is the third group of patients, Senthil, where you had a problem?
So mass bleeding and not identifying duct. These are the three reasons for conversion.
And laparoscopic ultrasound, much as
So
we say,
laparoscopic ultrasound came.
did not really help.
Ultrasound.
So now it's happening.
So that's for the experts. So which would you recommend? Which would you recommend for the the neophyte not to start off with? Like small duct disease. Anything else you would suggest?
If you have a mass lesion, it's a problem. If you have complete distortion of anatomy due to if you have a complex inflammation with pseudocysts in the lesser sac, everything would be such a mess that it would be probably better to drain the pseudocysts first, let the inflammation subside, and perhaps that may give you a second crack, which can be done by laparoscopy. It's the more complex the distortion of anatomy, the more trouble you are going to saddle yourself with. Because in robotic surgery, with the preliminary, contact with robotics I have, I'm able to perceive that in a very tight, confined space, it works fantastically. Because then you are moving within that space, the degrees of freedom give you great facile movements. But if you have to move over a large area, which is what is... I believe we are having another speaker. So if you have a large area where you have to work, sometimes it can become a challenge for the robot, because you have to just move your field from one area to the other. The body and the tail can be far away from the head, and it'll be quite a task. Zero in on a panoramic view. So that I see could be a potential problem, although I have never tried it yet. But the Becker procedure is a promising one. But doing a neck transection is not going to be easy in a substantial number of cases. So you are having a benign disease. The first thing you want is no mortality. You want something which has long-term durability, if you can. If that's a very laudable objective. In that case, you want to make sure you get this chance. You want to make it count. You have to really work out what policy you're going to have, what strategy you're going to have surgically.
Another question I constantly ask you is, and we also have a lot of such patients, fairly symptom controlled patients, but huge stone load. We still see a lot of such patients. Do we, advocate surgery, or we'll have a close follow-up on those patients?
At the moment, we don't operate them. The quantity of stones is not a criterion. Some patients are very concerned. They do talk about, how Malayali patients are even more inquisitive than other parts of the country. They want to ask you, leaving those stones there is a problem. So I usually give the example that we have nothing really to work on. If you had pain and if I did surgery and you were relieved of the pain, that would be a step in the right direction. If you didn't have any symptoms to start with, and if I operate you, and if there is even the most minor complication, then it would be unacceptable philosophically for both the patient as well as the treating doctor. So if on the other hand, I give them the analogy that if you're wheeled in with a road accident and bleeding from every orifice, then I would have no hesitation in taking you into OR and doing an emergency operation. But I would not do the same for chronic pancreatitis. So I tend to explain to them that I am frightened of a bad result, and therefore I would not want to intervene at this point. It usually works.
But sir, the counter argument is you can reduce the incidence of malignancies by acting early, especially with huge stone.
We have been following up our patients very carefully. Now there is a large number of patients who've been followed up for more than 12 years. 6 patients have developed cancer in spite after the surgery. That is way less than the incidence of cancer in chronic pancreatitis. So Puneet, for example, is always pitched for my publishing the data by saying that at least provocatively, it will suggest to the public that this may be a prevent cancer. But I've been wary of that because I do not want to send the wrong signals out. Also, the patients who had cancer had extensive residual calculi. So maybe there is inflammation, dysplasia, cancer sequence. We published, incidentally, in 1992, the first case where we had dysplasia and cancer in the same specimen in different areas. So I think the dysplasia cancer sequence has been established, but there is, because pancreatic surgery is still not a Sunday afternoon stroll in the park. And therefore, it's the same story of gallstones and cancer and prophylactic surgery for gallstones. This is even more complicated because pancreatic surgery, even in the best hands, has morbidity definitely, and who knows, the odd mortality as well.
So there is a question in the chat box. The question is, if you accidentally injure the bile duct during the head coring, what is the best thing to do?
So it's now we are very impressed by the benefit of ICG injected an hour and a half or so before surgery, which gives you very good visualization of the bile duct. If you're doing it laparoscopically, it's a big disaster because your scope needs to have the near infrared fluorescence. If you have one of those machines which have no near infrared fluorescence, then you're in trouble. 3D does not have it, for example. On the other hand, once the robot is in regular use, I propose that we will use it extensively because you can flip switches and simply see for ourselves. So we wouldn't open it unless we wanted to. But if you do open it, don't mess around with it. Don't try to enlarge it. Do not try to suture it. The more you tamper with it, the more blood supply disturbance that you will do. I would recommend that you place a stent through the opening into the transampulla and up the bile duct just to prevent the axis of the bile duct from being disturbed. And then, if required, you can replace it endoscopically at 6 weeks or 2 months and not do a thing. If there was a previous biliary obstruction, you could use it as a drainage. And in any case, do not worry about it. But if you do a accidental injury to the posterior capsule also along with bile duct injury, then you have a serious problem on your hands. Then probably you should go back out and have a cup of coffee and come back and do a Whipple resection, because that's the only thing that will work in that situation. Because you now have a bile duct opening and you have a posterior capsule opening as well. And unlike a posterior capsule opening, which you can just sew from the back, you have cauterized the duodenum, you just suture it, and that's the end of it. If you have both these, then you have trouble. And especially, we've encountered one case where the anterior wall of the bile duct, the posterior wall of the bile duct, and the posterior capsule were all injured. And that patient underwent a Whipple resection. The patient is doing well 20 years later, but definitely has pancreatic parenchymal functional deficiency. And that is a major cause of morbidity for him.
So the other question is CCP with benign head mass with obstructive jaundice without pain.
This is a Puneet question. This is a Puneet question, because we have only seen a handful of these cases for close to 37 years of my practice. And first of all, the question is, are we dealing with chronic pancreatitis as the cause of this biliary obstruction? So if there's no mass in the bile duct, if there's no stricture on the MRCP, are we dealing with something else? That's the first question. And if you are still dealing with it, I would just place a stent and wait. I would not do a hepatic jejunostomy. I would want the disease to reveal itself. And I kind of believe that there would either be a malignancy lurking somewhere, or there would be I would do a US, of course, to look for a small tumor and place a stent and observe for some weeks at least before I decide what I do. I think I wouldn't have a knee-jerk reflex about operating such a patient. Obstructive jaundice with a bilirubin of more than 5 milligrams in chronic pancreatitis is by our criteria, by Dr. Jaswant's criteria from Stanley, and from most people's criteria, Philip Bondman's criteria from South Africa, is almost always malignancy. And you must treat it as that. Maybe then you should do a Whipple resection.
So fries with HJ, you will not suggest. That's what you are.
No. I didn't say that. The fries with HJ typically will have a 3 millimeter to 3 milligram bilirubin, or will have a dilated bile duct with raised alkaline phosphatase, with maybe just transient jaundice or some cholangitis. That's the typical story of the benign mass in the head with biliary obstruction. In that case, it's perfectly, you have the following choices. You have a hepatic jejunostomy if the inflammation in the bile duct is very considerable and the duodenum is not supple, and if the bile duct is also not very dilated. If the bile duct is nice and grossly dilated and the duodenum is supple, you can do a choledochoduodenostomy. You don't have to do a hepatic jejunostomy. And if you do an operative cholangiogram, and I've shown this many times in my presentations, you can really see where the stricture is, how long the stricture is. The stricture is in the intrapancreatic portion of the bile duct. Then you can very well open it in the head coring, and that can do just as well. We have close to 60 patients who've had internal drainage, some by accident, some by design, and they haven't had any major deleterious outcomes.
I think the question was, with regards to the head mass, benign mass with on the background of CCP, would you go for endoscopic just biliary stenting or operate fries along with the HA? That's the question, sir.
No, if there's a benign head mass, then I guess you would have to do a fry. If you have a patient who just has a biliary dilatation without a mass, then you look for adenocarcinoma by US and then consider a stent, temporarily at least.
Just a technical question, sir. You will be doing the hepaticojejunostomy the same limb or in a different limb?
Yes, same limb. If you may have to reverse it. Normally, my end of the jejunum starts at the tail.
Yeah, everyone does like that.
So if you have to do a good HJ and you have to lie it properly, you may have to do it the other way around. It's a major challenge to do a HJ and a PJ together, especially if you have done a good head coring. If you've done a good head coring, the inferior portion of the pancreas is also opened up. So whatever you put, the jejunum has to come down to the pancreas and then go up to the duodenum, jejunum again, and then come back. I'm quite happy sometimes to do a second rule loop as well to the bile duct, which is fairly easy to do, and there's no lie issues.
But as far as the lie is concerned, sir, generally we prefer taking the rule limb onto the right side of the middle colic, but you prefer on the left side of the middle colic.
I like it on the left side because this head cord portion is very large at the end of my operation, and I want a lazy curve of the jejunum. I don't want, if I take it in the right side, then the jejunum actually enters onto the head cord, and it doesn't lie nearly as well. Here, what happens is you have the jejunum coming from the tail, and there's a very lazy bend which takes it to the head cord area and returns to exit into the infracolic compartment. And we've of course tried both techniques, and we found this better. Maybe if you try it a few times, you may like it.
Yes, because I was always under the impression the lazy curve what you're mentioning will be with on the right side rather than the left side, because it takes an acute bend to go on to the left side of the middle colic. That's what I present. That's why I choose to go for it.
You just try it once, and perhaps
sir, I'll do it. Roshan, Dr. Banwarlal, any other questions? I'm enjoying the interaction, sir, more than anybody else.
Yeah. This likewise.
Thank you, sir. Thank you.
Thank you, sir. And thank you, Senthil sir, Puneet Dhar sir. Now, I request our Secretary, Dr. Devorsi Sharma sir, for declare the result of the quiz and vote of thanks. Sir, please.
Result of the quiz will be told in the next seminar on the next online CME when we'll have it in the next month. We definitely have some announcements to be made, particularly of the next CME, which will be on the 5th, where we'll be discussing something like that, the recurrent pyogenic cholangitis. Dr. Sukanta Ray is a professor and head of surgical gastroenterology in Calcutta, IPGMAR Calcutta. He's the speaker. I'll be moderated by Dr. Noor, Dr. Jogendra, and Dr. Prakash Shashmal from AIIMS Bhubaneswar, and convened by Vishwarup. We have numerous other programs coming up. As Varghese sir has said, that we have our MRC Lens on the 3rd Thursday from 3 to 6 p.m. This time, Professor Rao Sak Chanwant from Thailand, he's going to demonstrate laparoscopic liver resection live, probably. That is what is the plan is. So we wait to welcome all of you on that particular day on 21st of September from 3 p.m. This will be something very interesting, and we hope to see you all on that day. And we have numerous programs, other events as the basic in our Smart Center also. This is the list. I request all of you to go to our Smart Center website to get into this list, where we have the basic hernia course, the upper GI course, the proctology courses, and the bariatric courses also coming up in the near future. This is at the 9th floor of the GEM Hospital, Chennai, and we have got a state-of-the-art laparoscopic training center there. So all of you are welcome there. Please do visit that place and join one of the courses being held there. It will not be right for me if I don't speak about AMASICON this year. The AMASICON, which is the marquee event of our association. This is the annual conference, which will be held from the 2nd to the 5th of November 2023 in Raipur. I wait to welcome all of you. Please join. Our bursary applications have closed in. Our scientific program is almost ready, and we have 150 faculty coming from across the country. Around 25 international faculty is also visiting AMASICON. Request all of you to be there to interact with the most prime laparoscopic surgeons in the country and the Southeast Asian groups, different Southeast Asian groups. And this is probably will be a unique event to 2023. We expect around more than 2,000 delegates to be attending AMASICON this year. It is my proud duty after this to say the vote of thanks, I think, Bhavar. These are the skill courses that we are having in the next. One is in Ranchi, which is coming up in September, and another is in Kathmandu in the last week of September and 1st of October. Beyond that, after AMASICONs, we have in Delhi, Hyderabad, and the 100 skill course is coming up in Coimbatore in the first week of January. It's my duty to say both of thanks. Bhavar, should I say, or you're going to say that?
No.
Okay, thank you. It's a pleasure to have Dr. H. Ramesh speaking here and sharing his vast knowledge on chronic pancreatitis with AMASI, and as well all the delegates who were there. I thank all the moderators, starting with Dr. Puneet Dhar, Dr. Senthil Nathan, and the others. I thank also the convener to be here. And last but not the least, I thank Dr. Varghese sir, and Palnivalu sir is here. Sir, thank you for the opportunity to be here among all of you. And Roshan, I thank you. My computer had slipped at that time, means the connection had slipped. It took over that time. Thank you very much. Thank you all. We'll see you in the next online CME. Thank you.
Thank you.
Thank you.
Bye.